All right, good morning, guys. My name is Paige, and I'm going to continue your lesson on airway management in your chapter of airway emergencies. I apologize for my voice. The allergies are kicking my tail right now, but I will do my best so that you can understand me. Just as a review for you and I both, I just want to make sure that yesterday you covered simple airway devices such as nasal cannulas, non-rebreathers, and the bag valve mask. Yes, and you learned the techniques associated with the BVM, the head tilt chin lift, and the modified jaw thrust. Yes, wonderful. All right, so that means today we will continue with the information you learned yesterday, and we'll just add to it. So let's talk about how we control or try to control an airway in an unconscious patient. Because up until this point, the non-rebreather and the nasal cannula is typically used on conscious, responsive patients. The BVM, you may be assisting with ventilations. But most of the time when you're using a BVM, they're unconscious. And what that means to us is they have an increased risk of aspiration, so they're just laying there. They have no cognitive function of their brain. So they may not have a gag reflex, they may not be able to control when they vomit, and they really can't control their tongue. Like the muscles in their tongue kind of just flop backwards, whichever position they're laying in. So the reason this is problematic is when the tongue is floppy and you're using a BVM, you're literally blowing the oxygen against the tongue and the air is just kind of like sitting in their mouth instead of being funneled to where they need to go. So luckily, we have devices that are used to control the movement of the oxygen. So we have these devices that either displace the tongue so that the air can move freely behind the tongue, or it can go into the nose, into the nasal pharynx, and then pushes the air behind the tongue. So let's discuss the two devices I've been telling you about. These are called adjuncts, and it simply assists with your ventilations. So we're going to start with the OPA, the oral pharyngeal airway, and then we'll move on to the MPA. So the OPA goes into the mouth, obviously. It displaces the tongue, so it compresses it down and allows the oxygen to go past it. However, before we put anything in a patient's airway, we have to ensure that it is clear. So we want to take a good look, make sure there's no blood, dirt, sputum, saliva, vomit that we need to suction out before we put in an OPA, because we are pushing something into someone's mouth. So please ensure that you have a patent airway. So we've suctioned, we've cleared it out. Our partner is using the BVM, and we are trying to find the OPA in our bag. So we found it. We have an array of sizes. We have everything from baby, pediatric, neonate to very large adult. So you are going to measure it from the corner or to the middle of the lip, somewhere in between the section, to the earlobe. So it's kind of like this space right here. It follows the palate of your mouth. So it's typically the earlobe, maybe not all the way there, but this curve in your mouth. So you want it to go to there. You don't want it to be too short. If it's too short, it's going to obstruct the airway. So you want it to go from here to here. Once you've measured it, you're going to open the patient's mouth using the scissors technique. You're going to push your finger and your thumb in and push it against each other. Open the mouth. You're going to insert the device with the tip up. It's going to look funny. You're going to put it in, and then you're going to rotate it. We don't put it in just like that because you're going to push the tongue backwards. You're going to put it in the mouth, tip up. Once you pass the palate, you're going to rotate it so you have room in the mouth to rotate it, and then it should just slide right in behind the tongue. Once it's in its proper anatomical position, you'll push it just a little bit further until this flange, this little tip right here, rests against the lips. Once it's in place, you will take your BVM, put it back on the patient's mouth. Remember your C and E, your head tilt, chin lift, and give a few good breaths. You should feel that there is much less resistance when ventilating the patient. That's one of the most clear indications that it's in the right place. So let's say that we went in, we suctioned, everything was great, we went to put it in, and the patient started gagging. So that is our contraindication for using an OPA. We are not going to put anything into someone's mouth and make them gag, because now we are, obstructing their airway. So we're going to remove it. We're going to have our partner continue using the BVM, and we are going to reassess the situation and be like, well, we have another adjunct. It's called an NPA. So obviously this one goes into the nose, it goes into the nasal cavity, and then it seats right behind the tongue, like right behind where your tongue connects. And it just kind of blows that air where it needs to go. It kind of just tunnels it where it needs to go. So just like the OPA, we have several different sizes, ranging from pediatric to adult. Back in the day, they used to say that you could measure the patient's pinky, and it would be pretty much the size of their nair. It sometimes works, sometimes doesn't. So the book way is you go from the tip of the nair right here to the tip of the earlobe with the arch up again. And this should be the distance that the NPA needs to sit at the back of the throat, the back of the oropharynx. So once you've measured it, you've determined this is the one you need to use. We're going to lube it up because there's no saliva in the nose, So we're going to lube it up with some petroleum jelly. We're going to lube it up with water-soluble lubricant. It should be taped or tied to your NPAs in your bag. You're going to lube it up. And then you're going to insert it into the nostril. It's typically the right nostril because it is the larger of the two. This may be a time where you're like, oh, wow, I have a bigger nose than the other. You may not have noticed that your one nostril is larger than the other would until right now. So the right one is probably larger. You're going to insert it with the bevel towards the septum, so that the hole towards the septum, and it just goes right on in. You should not have to push it too hard. You may have to do like a little bitty wiggle, but it shouldn't be too difficult. If it's too difficult and you're pushing with a lot of force, you may cause an epistaxis, which is a nosebleed, and we don't want to do that. So do not put any force on it that you think is going to cause them to bleed. If it's not going in, choose a smaller size. Sometimes you can use the other nostril. Sometimes you can just wiggle it around a little bit. There is a little bit of resistance, but it should not be significant. And then you have patients that have lots of boogies and stuff. That's a whole nother situation. Sometimes that takes like a soft suction tip and get up in there and clean it out. I've seen some pretty gnarly noses. But anyway, that's an NPA. That's how you insert it. So once you've got it in the nose, you've got it seated, you're going to use your BVM. Once again, you're going to ventilate the patient just as you have before, and you should feel some less resistance than before. Some people like to insert two. It's not going to cause any problems. It might look a little funny, but you're more than welcome to insert more than one. So obviously, there are contraindications to using an NPA. If the patient has any type of deformity or instability of the nose or the maxilla bones right here, or any obvious like contusions to the subdural area, we're not going to insert anything into their nose. For one, we don't want to push any like bone fragments into the nose, into the airway. We also don't want to run the risk of pushing an NPA the wrong way and it going up into the sinus cavity or into the cranium. We don't ever want to push anything into the nose when it's not a stable environment. So if you're in a situation where the mouth is so destructed that, or deformed that you can't put an OPA in, there's too much deformity, too much instability of the face, you're not going to want to put one in either. In those situations, you're going to use the BVM, you're going to suction until you can get an advanced provider, such as paramedic, to show up and secure that airway. You kind of just have to make the best of what you have. All right, so everyone has a mannequin in front of them. You all have your OPAs and your NPAs. Your mannequin heads don't have fingers, so you will be measuring from the nose to the ear. And we will go through the steps of inserting each of these devices.